This conference will now be recorded.
Thank you everyone for joining us today for a presentation from members of our head and neck surgical team within the division of Otorhinolaryngology. We'll be having Dr. John Maddalozzo present for us today on Thyroglossal Duct Cysts. Please feel free to use the chat box that's in our presentation today. For any questions you may have, we'll have a few minutes after the presentation to address those. And now I would like to introduce Monica Heron, who's one of the physician assistants within ENT.
All right, good afternoon, everyone, and thanks again for joining us. As she said, my name is Monica Heron. I support all three of the surgeons that with the head and neck team that you'll be meeting today. My contact information is here on this slide, and I'm always happy to help facilitate appointments or imaging or let you know what's happening in the hospital or during surgery. We work with the physicians in all of those capacities. We also have a new head and neck website attached to Lurie's main website, which has an email address, headandneck@luriechildrens.org. You can use that email. I check that along with our head and neck nurses. We'll get back to you. We can help you with facilitate anything you need through the email. You can give that to parents as well. Just want to decrease as much red tape as we can. So I'd like to introduce Dr. John Maddalozzo. He is our section chief, and he's here today to talk to you about a lot of his expertise. He's got plentiful expertise, but a small portion of it today regarding thyroglossal duct cysts.
Thank you. And we're very excited about this. Our section is dedicated to helping children with advanced problems in the head and neck and make sure that they're done correctly. And we are also supported by our division, our entire division of ear, nose, and throat, otolaryngology, head and neck surgery. And I will happily welcome any questions during or after the presentation. So without ado, Monica, if you could put up the slides, I would like to begin the talk.
Yes, I actually, this will take me a second.
All right, no problem.
In the meantime, while Monica's pulling that up, I just wanted to remind everybody we do have a fairly new number at Lurie Children's. It's 1-855-LURIE-MD, and that is a 24-hour, 7-day-a-week phone line that will allow community providers to get in touch with a Lurie physician. So if you have questions on what the next steps are with kids, or if you need to make a referral or send somebody in for testing, Lurie MD is the line for you. It's 855-LURIE-MD.
Okay, good. Okay, very good. All right. Can I advance them or should you advance them?
I will advance them. It's on my computer.
Okay. All right, real good. So as stated, I'm John Maddalozzo. I'm a professor at the Feinberg School of Medicine, and I've been at Ann and Robert Lurie Hospital for 30 years, and there's a beautiful picture of our campus and facility. So if you can advance. Next. Okay, so what I'm going to do is I'm going to talk about, go back. Go back, Monica. Okay. How in the talk, what I'm going to do is give a general overview and how I found the treatment of thyroglossal duct surgery when I began practice, when I was a resident, what I changed, what I do, and how I currently do thyroglossal duct surgery, and This is based on, I've had experience with more than 1,000 of these surgeries. Next. Okay, so we'll talk about the embryology. During the 4th week of gestation, the epithelium and the mouth, the area that will later become the foramen cecum, evaginates and forms a tubular structure that will become the thyroglossal duct. Next. The duct extends and terminates in the lower mid-neck, and the distal end becomes bilobed and forms the thyroid gland. Thyroid development is usually completed around by the 8th week of gestation, and at that time, the duct should dissolve. Next. Between the 8th and 10th week, the thyroglossal duct involutes. Persistence of viable thyroglossal duct epithelium results in what we know as a thyroglossal duct cyst. So therefore, a thyroglossal duct cyst can occur anywhere along the duct's natural course. That is from the foramen cecum to the thyroid gland. Next. During the thyroglossal duct's descent, the hyoid bone is concomitantly undergoing anterior fusion. The tract, therefore, the tract, therefore, assumes an intimate relationship with the structure. Okay, and this is a micrograph of a surgical specimen, and here you can see the hyoid bone, and this here is the epithelialized portion of the thyroglossal duct cyst. Next, please. Now, there was a classic paper done on autopsy specimens and surgical specimens in 1977 by Ellis and von Nostrom. And what they demonstrated, and this was based on greater than 500 autopsy specimens, is that it demonstrated that the tract usually is adherent and passes anterior to the hyoid bone and then hooks around its inferior border to lie in a concavity and on the posterior surface before continuing its descent. It rarely goes through the bone. So it was primarily thought to be anterior to the hyoid bone. Next, please. Okay, so what Ellis and von Nostrom said was true. However, in my practice, images like you see to your right, these kinds of things bothered me. And you can see in this sagittal CT that the tract is going posterior to the bone. Next. So this stimulated a study that I did with one of the residents at Northwestern, who is now a section chief at Vanderbilt. And what we found is we studied our own surgical specimens, and we found out that they're usually lined with squamous or respiratory epithelium. And then we found out that follicles were present in about 46% of the specimens that where the tract could be identified. However, removal of the tract did not affect thyroid activity. Next. And could you go back? I think we missed a slide. Monica, go back one. Okay, so yes, so in that study, we also found that in surgical specimens where the tract could be identified, it was anterior to the hyoid bone in about 72%, but in about 30% of the cases, it was posterior to the bone. Okay, advance. Okay, having established these histological facts, these images still bothered me. Okay, and so this is where through then subsequent cadaver dissection that I did and from surgical observation, we just came up with the concept of the posterior hyoid space. Advance, please. Okay, so classically and erroneously, the insertion of the thyroid membrane is shown here to your right, and usually it's shown is inserting onto the inferior border of the hyoid bone. And what I have found is that it doesn't insert there. The strap muscles do. Next. And so what we found is that it actually inserts on the epiglottis, and then in a primary insertion, and then a secondary insertion inserts on the superior rim of the hyoid bone. And this creates a space or a pocket here where you can have thyroglossal duct tissue. And this can affect, when you do surgery in this area, it can affect recurrences. Next, please. Okay, so I already described this, and just to reiterate that there's a cavity here. Next, please. So the boundaries is ventrally is the hyoid bone, dorsally the thyroid membrane, superiorly the reflection of the thyroid membrane and its insertion on the superior hyoid bone. And actually up here, that reflection also contributes to the vallecula of the tongue. Next, please. Next, we already described this. Okay, and so this just demonstrates that in a cadaver specimen that this space exists, and it has been overlooked because oftentimes when you do autopsies, they transect the larynx. When they do an autopsy, they take the larynx and trachea and lungs out in one piece, but they usually make the cuts underneath the hyoid bone. So they miss the space for many years. So it's an opportunity for us to describe it, as it has surgical implications here as well as in other areas. Next, please. So this is an intraoperative photo that demonstrates the hyoid bone after it's transected. That requires transection in this operation for thyroglossal duct cysts, and the membrane forms a hinge, and that is the secondary reflection that we spoke about. Next, please. Okay, appreciation of this concept allows the surgeon to have complete resection of the hyoid bone and surrounding tissue. Next. So how does, and that what we described also can affect recurrence in this situation. So the clinical presentation of the thyroglossal duct cyst. Their most common congenital malformation found in the neck and account for 70% of congenital cervical abnormalities. It's postulated that approximately 8% of the population has a thyroglossal duct cyst. They usually present as asymptomatic anterior cervical masses lying over or just under the hyoid bone. Next. Monica. It is recommended that thyroglossal duct cysts be removed because they are prone to recurrent infection. And once they start, they usually don't stop, and they often result in ulceration of the skin. Rarely, 1%, less than 1% are malignant. And usually that represents when a malignancy does occur, it's a papillary carcinoma. Differential diagnosis includes adenopathy, dermoid cysts, and ectopic thyroid. Next, please. Now, with ectopic thyroid, there have been multiple reports of inadvertent removal of ectopic thyroid tissue, which was mistaken as a thyroglossal duct cyst, and which resulted in subsequent hypothyroidism. In an effort to avoid this kind of complication, pre-op imaging was advised. Next. Next. When I, no, go back one, please. Okay, when I trained, preoperatively, thyroglossal duct cysts were imaged with I-123 isotope. And thyroid functions were usually ordered. And I had a problem with this because if the children were clinically euthyroid and we were just looking to confirm if it was a cyst, I thought this was a little bit of overkill. Next, please. So I started using ultrasound, okay? And most people now would advocate using this, and this resulted in another paper after I lectured on this extensively. But ultrasound is not used so much to characterize the cyst. We identify the cyst, but we use it really to identify that there's a normal thyroid gland. Next, please. So if the normal thyroid gland is identified and the patient is clinically euthyroid, no further testing is usually required. We order CTs and MRs to evaluate thyroglossal duct cysts. It's usually reserved for recurrences or cases with unusual location or intralaryngeal, or I should even extend to that a base of tongue involvement. Next, please. Okay, so these are some soft guidelines. These are not hard cement rules, but these are some guidelines with ultrasound. Thyroglossal duct cysts usually are hypoechoic and avascular, okay? Dermoid cysts are also round, okay, but they usually have a complex matrix. Lymph nodes are hypoechoic but are more oval shaped and demonstrate vascularity with Doppler. Now, really, with ultrasound, the only thing you can really tell is you can differentiate a cyst from a lymph node, but you really can't tell what kind of cyst you have. Next, please. And sometimes we pick this up on prenatal ultrasound. And usually in prenatal ultrasound, they'll pick up lymphatic malformations, teratomas, other things like that. But occasionally they will pick up a thyroglossal duct cyst, and that is the dot we're seeing right here. Next, please. So surgery of the thyroglossal duct cyst. Now, the reason we remove this, remember, is primarily for recurrent infection. However, malignancy cannot be excluded. So historically, simple cystectomy was employed to remove those, and that resulted in recurrence rates of greater than 50%. So basically, the development of thyroglossal duct surgery has been an effort to completely remove the disease process and prevent recurrences. So in Germany in the 1800s, Dr. Schlang said, based on embryonic principles, we should also remove the central portion of the hyoid bone. And that dropped recurrence rates to approximately 20%. Next, please. So in Dr. Sistrunk, who is pictured down here, he began his career in New Orleans and then ended up in Mayo Clinic in Minnesota. He started doing thyroglossal duct surgery in 1910, but in 1920, he summed it all up and proposed not only removal of the central portion of the hyoid, but also a cuff of tongue musculature aimed at the foramen cecum. This resulted in recurrence rates of 4 to 6%. However, you know, in those days when they did studies, they really didn't do close follow-up of the patients. So if people were lost to follow-up, it was considered they didn't recur. Today, if you do meta-analysis, international meta-analysis, the recurrence rate with a standard Sistrunk procedure is about 10 to 11%. Next, please. So recurrence is really the result of incomplete resection of abnormal tissue. And in my opinion, this is the presence of microscopic suprahyoid that's in the ductules that come off of the cyst, and 2, incomplete resection of parahyoid tissue. So that's why that anatomy lesson about the posterior hyoid cyst and this type of thing is relevant, because by using and applying the concept of the posterior hyoid space, this reduces recurrence rate to about 1.5%. And this is follow-up in 17 months average. And it has been shown that in previous studies that most recurrences will manifest themselves in the first 4 months after surgery. Okay, and so now this technique is not only used at our institution by our surgeons, but it is also taught at other major pediatric centers. Next, please. So there are other complications that are associated with cyst trunk procedure that I want to share with you. And those are inadvertent entry to the airway, which this may require tracheotomy, neurovascular injury, which can result in hemorrhage or paralysis. The structures at risk are lingual artery and vein, hypoglossal, that's the one of the tongue, and superior laryngeal nerves, hypothyroidism, postoperative hematoma and airway compromise, and recurrence. Next, please. And so we prevent major complications by, when we do the surgery, and this is a technique that I described, is you identify the notch of the thyroid cartilage and use the thyroid membrane as a conduit to go to the hyoid bone. And then you transect the hyoid medial to the tendon of the digastric muscle, which avoids neurovascular injury. Next, please. And this is just an intraoperative schematic illustration demonstrating this. And if you follow these principles, you avoid entering the airway and you avoid neurovascular injury. And if you use the concept of the posterior hyoid space, this ensures complete resection of parahyoid tissue, which decreases recurrence. Next, please. And then hypothyroidism can be avoided with pre-op imaging or intraoperative identification of the thyroid gland. And hematoma can always be prevented with placement of a drain. Next, please. And so that I just summarized, this is how, not how I do it, but how we do it, is how I did it. Now all of us do it at Lurie Children's. If there's a cutaneous fistula, we include it with the surgical specimen. We identify the cyst. We divide the strap muscles, identify the notch of the thyroid cartilage, identify the thyroid membrane, and then that posterior hyoid space. And this helps us avoid complication. Next, please. And then these are just some other little points that we've already discussed. So go on. Next. So then I just wanted to include, these are things that are often mistaken as thyroglossal duct cysts. And one is, the most common is the dermoid cyst. That's the second most common anterior midline congenital lesion of the neck. It results from errors in the fusion of embryonal structures. It consists of ectoderm and mesoderm. Most of these you see on the lateral edge of the orbit. You can also find them in the mouth, and a significant number in the neck. And this also requires surgical excision, but not as extensive as thyroglossal duct cyst. Next, please. And then this is a lesion that's rare, but I have quite a bit of experience with, and it's called the midline cervical cleft. And the reason I have experience with it is it's often referred to me in earlier in my career, it was referred to me as an unusual thyroglossal duct cyst. And this is a midline fusion, and it is associated with a fibrous band that connects the chin to the sternum of the chest. And this results in a contracture of the neck. And you treat this by excising the lesion and the fibrous band and repairing, bringing new tissue to restore the contour of the neck with a Z-plasty. Next. And this is an example of the fibrous cord. And this is the Z-plasties. And believe it or not, this heals very well. Usually about 6 months after the surgery, you don't even know that they were operated on. And I hope I didn't run through that too quickly. I think we're done now.
Mm-hmm.
And I'd be happy to entertain any questions that anyone may have. Okay, and please ask if you want to or wish to.
Dr. Maddalozzo, do you see your patients first at Lurie Children's or at the outpatient, one of the outpatient centers before for a consult, and then, or
I can see them at any location. Okay, and what I try to do, say for example, if it's a thyroglossal duct cyst, I can see them at the satellites, no problem, and I try to get an ultrasound on the same day. I'm big on concierge one-stop shopping. I don't think that people have to bounce back and forth for these things. So yes, I can see them at any location that I'm at.
Okay. There is another question. If congenital cysts are caught on the prenatal ultrasound, when do you recommend seeing the baby?
If there was a little bit of an echo there, you said if it's discovered on ultrasound, okay, what age would you recommend?
Right.
Removal? I would try to, you can actually remove it at any age. I would try to, for thyroglossals, to wait till they're over 1 year of age, as long as, but there are cases where kids have had recurrent infection or it's enlarged and they've had minor airway problems. I've done them at less than one year of age without any problem, but usually those were special instances. Does that answer your question?
Yes, thank you.
Anyone else?
Thank you. And is there any other questions from anybody? You can just speak up or type it into the chat box. Okay. We also wanted to ask or address really quickly about telemedicine appointments.
About what?
Are you guys doing those telemedicine appointments within ENT?
Yeah, we are all available for telemedicine appointments. I certainly have no problem with them, and I find them very useful as a screening tool, especially to initially evaluate somebody that has a head and neck mass, okay, because it can direct imaging and things like that for our initial encounter. And I think Monica has spoken to this, but I will speak to it also. We have within our section, we have reserved time every day for at least one of us to handle telemedicine calls. Okay?
Yep. So
and
if you
we
need,
welcome them.
Yep, exactly. So of the 3 surgeons and myself, one of us is available every single day to take an urgent telemedicine appointment. Those can be made through my chart, but again, that head and neck at luriechildrens.org email address. If you have a concern or something you'd like us to see pretty quickly, that's an easy way to get a hold of us right away. But we're happy, and we can orchestrate we go to all of the satellites. Someone goes to everywhere, and we're happy to see patients at the satellites. And we can, if there are other subspecialists that the patients need, infectious disease, endocrine, things like that, we can coordinate either in-person appointments or telemedicine appointments with them if they don't go to our satellites. So, like Dr. Maddalozzo said, we know Chicago's big and downtown can be a tough ride for everybody, but we want to make things as easy and convenient for families as we can.
Okay. I would like to conclude.
I didn't hear you.
Okay.
Yeah. No, you're muted.
I think you're muted now.
Yeah. Okay. Yeah, I'm having a little bit of trouble. I've got my phone in. Okay. We'll try this.
Yeah.
Can you hear me now?
Yes.
Okay. All right. I just wanted to conclude the program and thank everybody for joining us today. And hope you remember our head and neck surgeons within our division of ENT. And that concludes our program. Thank you.
Thank you for inviting us and including us. It was a pleasure.